Yeah, good evening, sir.
Good evening.
Yeah, very good.
Sir, you have to unmute, sir.
Yeah, a very good evening and warm welcome to all the participants. And I'm Dr. Rajat Kumar Shah. I'm the moderator for today's session. And on behalf of the Association of Occupational and Environmental Health, Haryana branch, I warmly welcome Dr. Kumar Kalita, today's guest speaker for today's topic. And as you all know, this is the series, the second series and the 9th issue of this webinar. And the topic for today is Nimotuzumab in locally advanced nasopharyngeal carcinoma. And before we proceed, I'll warmly welcome Dr. Kumar Kalita, and I'm privileged to give a very brief introduction about him. Although he's associated with us for quite some time now, and he needs no formal introduction, but I'll be privileged to give a brief introduction. So Dr. Kumar has presented and published many scientific papers in the national and international journals and conferences, and he has experience of working in the State Cancer Institute, Guwahati, Assam, for more than 5 years. And he has participated as a guest lecturer on preventive oncology at Mangalai in 2018, and presented various talks, seminars, and mini teachings and micro teachings on various topics related to medical oncology, molecular diagnostics, medical genetics and immunology, and metabolic diseases, molecular and clinical biochemistry and oncobiochemistry. And he has participated in various journals, journal clubs, done recent biochemical markers in different diseases. So he's a consultant oncologist in the State Cancer Hospital, Guwahati, and also he has a fellowship in clinical oncology. Again, a warm welcome, Dr. Kumar, and we are happy to have you today on this virtual platform. And I request for the deliberations for today. Thank you.
Thank you, Dr. Saha, for your warm and kind introduction, and good evening to everyone. So first of all, I would like to give my sincere gratitude to the Association of Environmental and Occupational Health for inviting me to talk on this very important topic regarding the nasopharyngeal carcinoma. The treatment modalities has changed to very much extent. Earlier, it was all about the chemoradiation. Now it is so the treatment regimen has changed. People are opting for more about the induction therapy that is in the form of neoadjuvant therapy. And recently, so the Nimotuzumab trial has come and been latest published in ASCO 2022. It is the latest publication. So we'll be just to go through all the details of the study. So can I share my slides? Okay, I will.
Yeah, sure.
Hope my slide is visible to all.
No, sir.
Not yet.
Okay.
Sir, should I share it from here, sir?
Yeah, if you have, then you can share it.
Yeah,
So,
I will share it.
yeah, yeah.
Yes, sir. It's visible now, sir. You can please start, sir.
Yeah. So today the topic will be Nimotuzumab plus chemoradiotherapy. So versus placebo plus chemoradiation in patients with locally advanced nasopharyngeal carcinoma. Uh, so that it next slide, please. Yeah, it was presented in recently in ASCO by Professor Yanshun and his colleagues. So we'll be discussing all the details of the study. Next slide. So this is all about the Nimotuzumab plus chemoradiotherapy versus placebo plus chemoradiotherapy in a locally advanced nasopharyngeal carcinoma. This is a prospective randomized controlled double-blinded multicenter phase 3 clinical trial based in China. Next slide. So the concomitant chemoradiation that I have already stated that it increases the survival in patients with locally advanced nasopharyngeal carcinoma. So it is one of the treatment modalities commonly used in the treatment of locally advanced nasopharyngeal carcinoma. And we from the in vitro study we have seen that nasopharyngeal carcinoma expresses the EGFR activity, and there is some also retrospective studies and some case series to see that the addition of the nimotuzumab is a anti-EGFR monoclonal antibody, and if we can add the nimotuzumab to the radiation along with the concurrent chemotherapy, it improves the clinical efficacy. So it has been tried in some phase 2 study in the past, and but it has not been still used as a combination chemotherapy with the radiation. So that was the thought process, and that was the rationale for using the combination of nimotuzumab along with the concurrent chemoradiation. So, and they would want to see, and they wanted to see how the patient will respond to that. Next slide. So this is just about the study design. The key eligibility criteria was the stage 3 and stage 4. It should have been 4A. So stage 3 and stage 4A largely considered as locally advanced nasopharyngeal carcinoma. And the primary tumor should be measurable as per the RECIST criteria and with a fairly good echo performance status. The KPS score should be more than equal to 70%. And the patient was randomized into 3:1 arm. Then arm A, they have received the nimotuzumab, that is the standard dose of 200 mg per cycle, along with concurrent chemotherapy. So nimotuzumab was used weekly regimen, so 200 mg per week. And the chemotherapy they have used in cisplatin 100 mg per meter square every 3 weekly in 3 cycle. And radiotherapy was used either with the conventional radiotherapy or intensity modulated radiotherapy or IMRT for about day 1 to day 5. The radiation generally goes from Monday to Friday, and Saturday, Sunday is usually off for the patient. So similar protocol was applied in the trial also. And it was continued for about 6 to 8 weeks. And in the placebo, they have used the only chemotherapy that is the cisplatin 100 mg per meter square every 3 weekly, that is the standard as of now, along with radiation, be it an IMRT or conventional radiotherapy. And the primary endpoint was to see the 5 years overall survival, and the secondary endpoint was to see the overall response rate, the clinical rate, and the disease-free survival, and the local regional recurrence-free survival, distal metastasis rate, and the safety profile of the patients. And sample of 410 was in the study would have a 90% power to detect a difference of 5 years overall survival with the nimotuzumab, 86% versus placebo. So that was a predetermined sample size, which a dropout rate of 20% they have estimated. So the sample size of 482 patients were determined as per their statistics criteria. Next slide. So number of patients treated were 483 as per the statistical criteria. Randomized to 3:1 arm. The arm A received nimotuzumab along with concurrent chemoradiation as a standard modality that we also use. And nimotuzumab was given as 200 mg every weekly. Out of the 483 patients, and the arm A that comprises of 361 patients, 53 patients discontinued, and ultimately out of the 361 patients, only 308 patients could continue the treatment and can complete the treatment. And in arm B, also similar number of patients were discontinued the treatment due to some adverse events or maybe toxicity to either modalities of treatment, and ultimately 108 patients can ultimately could complete the treatment. Next slide. Regarding the baseline demographics and the clinical characteristics, it was evenly matched in both the arm A and arm B. We have, if we can, you can see that the median age, the gender ratio, the Karnofsky score, distal metastasis rate is evenly matched. So most of the patients were without any metastatic disease, almost 99.7%, more than 99% in both the arms. And most of the patients were in the stage 3 and stage 4 that we have already stated. The stage 3 patient comprises almost 50.9% in arm A and 46.3% in arm B, while the stage 4 disease comprises 48.5% in arm A, while it was 52.9% in arm B. So mostly stage 3 and stage 4 patient without any metastasis with a good performance score, those patients were included in the trial. And number of Nimotuzumab, almost 96% of the patient in arm A could complete the weekly regimen, that is the 7 weeks of Nimotuzumab treatment, and almost 3.9% of the patient could not complete the standard 7 weeks Nimotuzumab treatment due to some toxicity, and almost 96% of the patient in arm A could receive the 25 fraction of radiotherapy. So, and almost 3.3% of the patient could not complete the standard 25 fraction of the radiotherapy. And we can see that the number of chemotherapy, almost 94% of the patient in arm A could complete the more than 2 cycles of chemotherapy, and less than 2 cycles of chemotherapy, almost 5.3% patients, so due to some toxicity. So most of the patients, almost more than 95% of the patient could complete the standard Nimotuzumab treatment. Radiation also almost more than 95%, and almost the 95% of the patient could complete at least 2 cycles of chemotherapy along with the Nimotuzumab. Next slide. So if we can see that 5-year overall survival, so we can see that the median follow-up was almost 75.7 months, and if you can see that 5-year overall survival rate, it was 76.9% with the Nimotuzumab and concurrent chemotherapy. It is a very good encouraging data for all of us, especially in advanced nasopharyngeal carcinoma, where the relapse rate, especially with the stage 3 and stage 4, those patients they have included mainly where the chances of relapse or recurrence is very high, almost 50% of the patients. So in that category of patients, they have given the addition of the Nimotuzumab would give us an absolute benefit of almost more than 12% with a good p-value. Next slide. Next slide. Okay, no, previous slide. You can, sorry. Yeah, regarding the 5 years overall rate in the PAR protocol set, so that was the analysis in the full patients. So as per the PAR protocol set, there is an absolute benefit of almost 10%. So if you can see that the 5-year overall survival rate with the Nimotuzumab and concurrent chemoradiation was 74.7%, with that of the placebo plus concurrent chemoradiation, which was 64.3%. So there is also a non-significant improvement in 5-year overall survival, but it was statistically not significant, but there is an incremental benefit almost 10%. Next slide. Regarding the subgroup analysis, you can see that irrespective of the number of fraction of the radiation therapy, and irrespective of the age group and irrespective of the staging, whether it is stage 3 and stage 4, in all the subgroups, the addition of the Nimotuzumab actually reduced the mortality rate. You can see that the most of the it is falling on the left-hand side of the line of neutrality, except those patients who could not complete at least 2 cycles of chemotherapy. In all other subgroups, irrespective of the number of the radiation therapy, irrespective of the age factor or the staging, so in all the subgroups, the Nimotuzumab could reduce the risk of mortality. Next slide. We can see that the disease-free survival, so there was the 3 years disease-free survival, it was 65.1% with Nimotuzumab and concurrent chemoradiation versus it was 60.3% with the placebo and concurrent chemoradiation. So there is also a non-significant difference in 3 years disease-free survival, which favoring the Nimotuzumab and concurrent chemoradiation arm. Next slide. So regarding the responses, so we can see that the addition of the nimotuzumab and with the concurrent chemoradiation, so we can see a very good improved in the complete clinical rate. So you can see that the 57.3% of the patients showed complete clinical response with the addition of the nimotuzumab versus 45.5% with the concurrent chemoradiation only. So from that data, we can see that there is improved complete clinical response of almost 13.3% with the addition of the nimotuzumab in the full analysis set. Next slide. Regarding the locoregional recurrence-free survival, so it was the 3 years rate was 94% with nimotuzumab and concurrent chemoradiation, and it was almost evenly matched with the arm B. And regarding the 5-year rate, it was 93% with the nimotuzumab and with concurrent chemoradiation, and it was 94.6% evenly matched in the arm B. So there is no any difference as far as the locoregional recurrence-free survival data at the end of 3 years or 5 years. It was not found to be significant. Next slide. Distant metastasis free survival. So 3-year rate is almost the arm B is slightly higher, but found to be non-significant. 5 years data is also found to be similar. So there is no any difference in the 3-year or 5 years distant metastasis free survival in the arm A and arm B. Next slide. Regarding the type of radiotherapy used, so almost the proportion of the IMRT, that is the intensity modulated radiation, it was similar in both the arms. You can see from the data that almost 76% in the nimotuzumab arm and the 76.7% in the placebo group. So in both the group, the IMRT, the proportion of the patient received IMRT was similar. It was 73.6% with the nimotuzumab concurrent chemoradiation, and it was 72.8% with the placebo and concurrent chemoradiation. So there was no any added advantage in arm A because the similar number of patients with the radiation technique. So the IMRT technique was found to be better. So there is better delineation of the dose fractionation. So in that category also, the arm A and arm B, there was no any significant differences. The numbers are almost same. So there is no any advantage with the nimotuzumab arm as far as the radiation therapy or the techniques of the radiotherapy is concerned. Same. Next slide. Regarding the radiotherapy type analysis response rate, so it was with IMRT technique, the complete clinical response was 68.5%, and in the nimotuzumab concurrent chemoradiation arm, and it was 59.8% in the concurrent chemoradiation arm. So the addition of the nimotuzumab has improved the complete response rate, in cases the patient used the IMRT, and a complete clinical and a complete response rate is also found to be significantly higher. You can see from the data that it was 51.8% with the nimotuzumab and concurrent chemoradiation, and it was 28.6% with placebo and plus concurrent chemoradiation. So the addition of the nimotuzumab actually helps the patients with the conventional radiotherapy. So it has helped immensely in patients treated with conventional chemotherapy. But regarding the IMRT, there was no any found to be advantageous with the use of nimotuzumab. Next slide. Regarding the safety profile, so incidence of the adverse drug reaction ADR in the nimotuzumab group was similar in both the groups. It was evenly matched. Adverse drug reaction, the percentage was 35.7% with the nimotuzumab concurrent chemoradiation, and it was 42.1% with the placebo and concurrent chemoradiation. Severe adverse drug reaction was 0.3% in arm A, and it was not found in arm B. Severe the adverse drug reaction that leads to reduction or interruption of the trial drug, it was almost evenly matched. Adverse drug reaction which leads to treatment discontinuation, it was also evenly matched. Grade 1 to grade 2 adverse drug reaction, that was 33.8% with the nimotuzumab concurrent chemoradiation, and it was 41.3% with the placebo and concurrent chemoradiation. And a grade 3 and grade 5 adverse drug reaction, so it was 17.7% in nimotuzumab concurrent chemoradiation, and it was 15.7%, slightly higher, but not thought to be significant. Other than that, it was evenly matched in both the group. There was no any differences at all. Next slide. Regarding the common adverse events, mostly it was laboratory examination. So neutropenia. So neutropenia was almost percentage was almost matched in both the arms. Lymphocyte count decreased. Lymphocytopenia was almost found to be similar. So though the percentage is somewhat different, there is increased ALT in 5.5% of the patients with nimotuzumab concurrent chemoradiation, and it was 11.6% with the placebo concurrent chemoradiation. Hemoglobin, so anemia was found in or the chemotherapy induced anemia or the therapy induced anemia was, it was 5.3% with the nimotuzumab concurrent chemoradiation versus it was 5.8% with the placebo concurrent chemoradiation. So others are fairly negligible. So the most of the adverse events they found were increase in ALT level, transaminitis, and the neutropenia, which was but it was fairly matched in both the groups. Next slide. So to conclude that we have seen a phase 3 randomized trial. We have gone through the phase 3 randomized trial. So mainly they have used the stage 3 and stage 4 locally advanced nasopharyngeal carcinoma. So in the arm A, they have used the concurrent chemoradiation, and along with that, they have used the weekly nimotuzumab, that is the anti-EGFR monoclonal antibody molecule. And in arm B, they have used the standard chemoradiation that is applicable all over the world. And they have found that the addition of the nimotuzumab in the locally advanced nasopharyngeal cancer has a better efficacy, and there was absolute benefit of 12.6%. So 5-year overall survival data they have presented in ASCO 2022, and they have stated that the 5-year survival increased by 12.6% the use of nimotuzumab with concurrent chemoradiation, with a 36% disease reduction, risk reduction. So HR ratio is very good actually, and the complete response rate also increased. You can see from the data that it was increased by 13.3%. So with the nimotuzumab, we can increase the overall survival of the patient, which is most important thing in a clinical trial. And also you can get a complete response rate, which is also a surrogate marker of the overall response of the patient. In both two important categories, the nimotuzumab definite advantage compared to the concurrent chemoradiation. And we have also seen that the nimotuzumab and chemoradiation has a good safety profile, though the percentage is slightly higher, be it in neutropenia or in the transaminitis, but it was not found to be statistically significant, just the numerical increase. And so that's it from my side. Any question or any discussion, we can happy to discuss. Thank you.
Thank you so much, Dr. Kumar, for an excellent elaboration. And so you explained very well about the study designs with the primary and the secondary endpoints, and the role of nimotuzumab plus the chemoradiotherapy versus the placebo plus chemoradiotherapy, and the 5-year overall survival rate and its impact on the stage 3 and stage 4 patients, specifically with those with relapse. and the reduction in the mortality rate, and also the disease-free survival rate, the impact on that. And you also described the improvement in the complete clinical response and the impact on the local regional recurrence-free survival at the 3 years and 5 years, and also the impact on the distant metastasis-free survival at the 3 and 5 years. And also the overall survival rate and the response rate of the radiotherapy type analysis. So it was well described. And the minor adverse drug reactions and also the common drug reactions in the form of neutropenia and the transaminase levels. So that was an excellent deliberation, Dr. Kumar. And with that, I'd like to open the floor for questions from the dear colleagues and participants. If you have any questions, you can unmute and you can ask.
In the chat box also, I think there is no any question.
No question in the chat box also. So I think the explanation was very much clear and vivid. And so thank you, Dr. Navakumar, for coming over and explaining this excellent presentation. And on behalf of Haryana branch of Association of Environment and Occupational Health, I'd like to give the vote of thanks. And the president of the Haryana branch, Dr. Suniket Mishra, is not available with us today because of some exigencies. And so on his behalf also, I'd like to extend the vote of thanks. And with that, I think we can conclude the session. Thank you, sir.
Thank you. Thank you
Thank
for
you
the
very much,
kind
sir.
invitation. Thank you.
Thank you, sir.
Thanks.